Okay, so it's 12:05. We're going to go ahead and get started. There's still some folks trickling in, but we'll let you can get settled as you arrive. My name is Audrey Gway. I'm the organizer with the BC Health Coalition, and I'm going to be our host for today's session. I'm joining you today from the BC Health Coalition's head office in Vancouver, located on the unceded Coast Salish territories, which have been shared since time immemorial among the Musqueam, Squamish, and Tsleil-Waututh nations. As part of our land acknowledgement practice, we invite you to introduce yourself in the chat and include the territory that you're currently on. Wherever you are today, I just want to invite us to take a moment to offer gratitude to the generations of Indigenous caretakers that have looked after our land and teach us to see ourselves in relationships with the land and with each other as inextricably tied as a requirement for health and well-being. So today we're here to dig into the issue of profit in long-term care. On behalf of the BC Health Coalition and the Council of Canadians, I'd like to thank all of you for joining us for the first of two webinars on seniors care. Next Thursday, we're going to be looking at the gaps in our current seniors care system. So I want to encourage all of you to register for that. We'll be posting a link in the chat later today. And then we also hope that this is the first of two of many more webinars that we'll be able to do in the new year. So we currently have 352 participants in the call today. So thank you and welcome everyone. We're going to introduce our speakers shortly, but I'm going to do a few tech housekeeping notes. We are recording today's session and you will be able to view it. We'll send a link within a week of today's webinar. You'll also have an opportunity later on to pose questions to our speakers. And what we are going to ask of you is to not use the chat for questions, but instead use the Q&A function. You can do that at the bottom of your screen. There's a little two bubbles and they're labeled Q&A. So if you click on that, you'll be able to type in questions and we will be monitoring that and coming back to it later on. So please do use that. And then the chat can be more for comments or conversations or introductions as they're happening now. We do have team members that are monitoring the chat, and so please feel free to type in any issues or ask for help, and we'll do our best to attend to that. And on that note, I want to give a quick shout out to our people behind the scenes, our tech team. We have AJ from the Council of Canadians, Usman from the BC Health Coalition, and Jolyn from the BCGEU, and they are doing the good work of helping us run this as smoothly as possible. So I think that's everything on the technical side. Let me introduce you to our moderator for today's panel. Kim Slater has been on a long journey of advocating for better seniors care through family councils. He's the chair of the Vancouver Island Association of Family Councils, which was established in 2010 as an umbrella organization for family councils from residential care facilities throughout Island Health. So thanks so much, Kim, for being with us today and helping our conversation go smoothly. I'll let you take it away.
Well, we'll see. Thanks, Audrey, and welcome again to everyone. We're very lucky to have the guest speakers that have joined us today. Pat Armstrong, distinguished research professor of sociology from York University. Margaret Mcgregor, family physician and clinical associate professor at the UBC Department of Family Practice. And of course, Lou Black, director of research and policy at the Hospital Employees Union. Here's how we're going to move forward today as a group. What I'm going to do momentarily is invite each one of our speakers to talk to us for about 10 minutes, to do a 10-minute presentation, and they're going to do it one after another. And following that, I'm going to invite the council of speakers to dive in a little bit deeper into the conversation. And during that time, we invite audience members to submit questions that you may have based on what you've heard or what you would like to talk about. And that will take us about 15 minutes. And that will be followed by the Q&A session. And we hope to wrap up by 1:25 this afternoon. So that's where we are. And I would like to jump right into it and introduce our first speaker, Dr. Pat Armstrong. She is a distinguished research professor of sociology, in fact, at York University in Toronto. She held a Canada Health Services Research Foundation, Canada Institute Health Research Chair in Health Services and Nursing Research, and has in fact published on a wide variety of issues related to long-term care, to healthcare policy generally, and women's health. She has edited books, including A Place to Call Home, Long-Term Care in Canada, and Women's Health, Intersections of Policy Research and Practice. The fact is that Dr. Armstrong has probably written more books than most of us have read. My first awareness of Pat Armstrong came when she was a principal investigator in a project called Reimagining Long-Term Care, an international study of promising practices in long-term care. That caught my attention. Pat, it was from Albert Banerjee, who I got to know in that project. So it's my pleasure to introduce to you Dr. Pat Armstrong. The floor is yours. I think you're muted, Pat.
I can try this again, maybe. Thank you for introducing me so elegantly. And thank you for the organizers, and thank you for the many who allow us to live on their traditional lands. I thought what I would do is start by saying that there are many forms that the profit motive takes in terms of the care for seniors. First of all, there's ownership. Ownership of the service or ownership of the subcontracted services, for instance, in long-term care. There's also the profit motive that pervades the way we organize work in those that are not necessarily for profit. And that shows up in the kinds of precarity in employment, for example, and in the gendered undervaluation of women's work. It also shows up in how much work we are leaving to be done unpaid, again, primarily by women, but not exclusively by women. And it shows up as well in the extent to which we transfer costs to individuals and households, even while the primary funding comes from the public purse. And finally, it comes in the form of private accountability rather than public accountability, accountability to shareholders rather than to those of us who are paying for those services, those of us who live in this country. So I think when we're talking about the profit motive, we have to think about all of those forms that pervade the way our health services and community services are organized. The other thing I wanted to say, because I want to be short and leave us lots of time to listen to the other two and to hear from you, is that when it comes to for-profit, we have to ask why. We've spent a lot of time talking about the problems with for-profit, but what's the reason for for-profit? What's the advantage of for-profit? It isn't better quality. It isn't more choice. It isn't cheaper. Now, one thing it is, especially when it comes to residential care, is that it keeps the full cost off the current budget of the government. It doesn't take it away, it just transfers it to future generations as opposed to having it in our current books. So so I think that making our argument for why we want to eliminate profit in these services, we have to begin by asking them why they think it should be there, and then addressing the one strategy I think that often is used to justify it, which is we can't go over budget this year, and so we can transfer the cost of those corporations putting in their money right now. Well, let's change the way we account, as opposed to saying the answer is for profit services. I also think that what we have to do is raise the standards, enforce them with verified data, and require transparency in those services, and that no new services will be funded that are taking some of the money for profit. So I want to stop there and leave lots of time for others.
Thank you. Thank you, Pat. Next, I'd like to introduce Margaret. Margaret Mcgregor, a clinical associate professor with the UBC Department of Family Practice. She currently, I believe, works as a family physician with the Home Visits for Vancouver Elders, Home Vive, I think is what it's called, the program in Vancouver. She's also a researcher in health services, where one of her interests has been in healthcare services for seniors, of course. She's published a number of studies on how ownership matters in long-term care. And in BC, she's been a leading voice for services delivered to seniors, kind of a go-to voice. Additionally, she's always willing to lend a hand to advocacy groups such as ours when they're trying to change the needle a little bit. So welcome, Margaret. The virtual floor is yours. Unmute.
Yes. Now
There we go.
I'm going to. Does that show up
Yes.
properly?
Yep.
Good. Well, thank you very much for inviting me to speak. And I too would like to acknowledge that I'm on the unceded territory of the Musqueam, Squamish, and Tsleil-Waututh nations. And thank you, Kim, for that lovely introduction. I'm going to use my 10 minutes to first review some basics about long-term care. And secondly, to briefly describe what we know from the research on facility ownership and quality, and of course, more recently on facility ownership and COVID in long-term care. So first of all, how do I move these slides along?
You can use the arrow keys on your keyboard, probably, Dr. Mcgregor, if you want to try that.
No.
That's not working. Are you in your presentation yourself right now, or are you in the Zoom?
I'm in, I've got doubles here. I'm gonna just switch this.
You just want to make sure you're clicked into your own presentation.
Yeah, I've got two screens on, and that may be what's causing the problem.
Sure thing, no problem. There you go.
Okay, good.
So now you'll just need to put that into presentation mode, but it looks like you're definitely in your presentation.
Okay. How's that? Okay, here we go. Who lives in long-term care? Well, we know that residents of long-term care homes represent the frailest members of our communities. In order to qualify for residence in a publicly funded nursing home in many provinces, an individual needs to have a high degree of dependency on others for their personal care. So you need to depend on someone else to wash, to groom yourself, to toilet. And that's as a result of advanced age, chronic disease, or some other medical condition. And that dependency is what we call frailty. And frailty, we now know, far more than age is a strong predictor of mortality. So in fact, the average length of stay in long-term care facilities, even with no pandemic around, is about 12 to 24 months. And these individuals are indeed some of the most vulnerable in our communities. So how do we fund long-term care? Well, long-term care has never been part of the Canada Health Act. And that's meant that it's funded through a mix of public payment, with the largest portion coming from tax dollars, and a smaller income-tested user pay portion that actually varies quite a bit by province. So who delivers the care? Well, this has also meant that the care is delivered by a mix of government-owned and operated facilities and by nonprofit and for-profit facilities that contract with provincial governments to provide care. And note, I'm not referring here to a very small number of private pay facilities. And this mix varies. So in BC, for example, roughly 1/3 of beds are government run by health regions, and 1/3 each are run by for-profit and non-profit facilities. In Ontario, 62% of beds are contracted to the for-profit sector, while 17% are delivered by government municipal homes, with the remainder being in the non-profit and charitable sector. So, what is the research on long-term care ownership and quality? While measuring quality in long-term care is multidimensional, there's lots of angles to what constitutes quality. Research has consistently demonstrated that public and nonprofit models tend to have better care outcomes for a wide range of indicators such as pressure ulcers, transfer to the emergency department, hospital admissions. And this slide just gives a few examples of the published research on ownership. Now, the most consistent difference seen is that for-profit facilities on average hire fewer staff compared to both nonprofit facilities and government-owned facilities. And this year, just before COVID hit, the BC Office of the Seniors Advocate did a wonderful report in which she studied the books of for-profit and nonprofit facilities in Vancouver and found that the for-profit sector failed to deliver 207 hours of care for which it had received funds over a 2-year period, compared with the nonprofit sector, which actually provided 80,000 more hours of care than it was funded to deliver. So there's also, if there's any question about whether staffing matters in care quality, there's a large amount of research on this topic. Research has demonstrated that more staff is related to better care, with the highest staffed homes performing better across a range of different activities. We also know that better quality is related to facilities with lower turnover. And surprise, surprise, there's good research that shows that if facilities have lower staffing levels, they're going to have higher turnover rates. This last bullet is a particularly interesting one, where researchers found that residents who reported having a relationship with at least one staff member was related to positive self-perceived health and a lower mortality rate in the facility. So despite this evidence, until 2018, at least in this province, there was profound government reliance on the private sector to expand long-term beds for many of the reasons Pat alluded to. We also found substantial subcontracting of facilities to outside for-profit agencies. So until the single site order in March of this year in our province that restricted workers to one site and provided a higher standard of compensation, staff often had no choice but to work at several facilities to support their families, and today still often carry workload assignments of 12 to 15 residents per shift, a number far exceeding best practice recommendations. So enter COVID-19. With its easy uptake among frail seniors, often living in shared rooms where staff has to move quickly between residents to manage unsustainable workloads that can make meticulous hand washing and donning and doffing PPE very difficult. It's easy to see how long-term care facilities can become a breeding ground for the virus to spread rapidly, and if left unchecked, can overwhelm a facility, something that we're continuing to see every day as we listen to the news. So what have we learned from the research about ownership and COVID? There's actually surprisingly quite a bit of research, even over this very short time that COVID has been with us, around ownership and outcomes related to COVID. A study by Charlene Harrington found that facilities with RN staffing levels under the recommended minimum had a 2 times greater probability of having a COVID-19 infection. 2 studies already have found that for-profit facilities have a greater probability of more extensive outbreaks. And 3 studies have found that for-profit facilities have a greater probability of more extensive outbreaks and more COVID-related deaths. One of these is a Canadian study by Nathan Stahl out of Ontario, who found that for-profit facilities had an almost 2 times higher probability of an extensive outbreak and a 78% greater odds of resident deaths compared to nonprofit facilities. So, in summary, based on the research, future public investment in for-profit owned long-term care should no longer be considered a credible policy option. We need family supporting wages and working conditions for all long-term care workers in the sector, with an end to facilities subcontracting services. And there is some preliminary research that we've done from the first wave that does suggest that subcontracting of care staff, even if it's by nonprofit facilities, is related to more severe outbreaks in our province. So irrespective of ownership, we need mandated resident to staff ratios consistent with the best evidence. And these days, at least 10% higher than the recommended staff ratios to accommodate the longer time it's now taking to do good infection control. We say that it should be staffed at 110% more than the expected and needed staffing level absent COVID. We've got good evidence from time motion studies and modeling that allows for easy calculation of the number and types of staff needed to meet resident care needs. Ratios of 1 care aide or to 10 or more residents is clearly unacceptable to meet care needs of virtually all residents now admitted to publicly funded long-term care. And minimum standards should be ratios much more close to 1 care aide to 5 to 7 residents, at least for days and evenings. We also need to develop staffing models that reduce the number of different contacts between residents and staff members, and that allow staff to provide more holistic care to a smaller group of residents. So these models are likely to be both good not only for infection control, but also to promote relational care, which is a key element that we found from the Armstrong study about reimagining long-term care to improve both residents' quality of life and staff's conditions of work. So I want to just finish with this quote from a study by O'Neill and colleagues that says, if increasing quality raises cost more quickly than it does revenues, profits must fall as quality improves. That is, a trade-off between profit and quality would exist. So public policy needs to come to terms with this trade-off and intervene on behalf of our most vulnerable seniors. And thank you for listening to me today.
Thank you, Margaret. Now I'll turn to Lou. I mentioned earlier that Lou's the Director of Research and Policy at the Hospital Employees Union in BC. In her role, Lou develops and supports research to advance working conditions of HEU members. Her research focuses on working conditions in healthcare, long-term care service delivery, and the integration of community and labor organizing. Lou is also co-chairing the BC Health Coalition Seniors Working Group, and has been with HEU for the last 14 years. HEU as an organization represents members in all areas of healthcare, from hospitals to group homes and labs to home care. And it's been around for 75 years, where they've advocated for better working and caring conditions. They've defended public health and spoken out against privatization. And the union itself represents 50,000 healthcare workers across BC. My experience is that when I see Lou and others like her advocating for workers, she's effectively advocating for better care for residents. And that reality is demonstrated time and time again. So welcome, Lou, and it's your turn on the floor.
Thanks, Kim. I'm going to try to not duplicate you, Margaret, but there is a lot of overlap in our slides and I should have spoken to you ahead of time. So I'll try to skip through those ones quickly. I also want to acknowledge and express gratitude for working, living, playing on the unceded territories of the Tsleil-Waututh, Squamish, and Musqueam nations. And Osman, you're operating my slide. So first slide, please. Ooh. There we go. So Kim already told you a bit about our union and who HEU represents. Next slide, please. I'm going to touch on who's operating long-term care in BC specifically. I'll try not to repeat what Margaret's already covered, how this impacts working conditions for workers and care for seniors, and finally just touch briefly on how we can start to try to make operators accountable. So Margaret already discussed the breakdown of ownership. This gives you a sense of what happened between 2001, so pre-BC Liberals taking government in BC in 2019. And the first part of this slide is based on work by Andy Longhurst that he published with the CCPA a couple of years ago. And you can see that over that course of time, because of the legislation and the regulation that the BC Liberals brought in, the for-profit sector was able to grow itself by 50%. To start to take 10% more of the overall share of the sector. That is, they started to operate 10% more of the funded long-term care beds, and the not-for-profit sector contracts in that same time period. And so specifically looking at who's operating those facilities in the among the for-profit operators here in BC, it looks different in different parts of Canada and the US, of course, but here in BC, Retirement Concepts, a name that's shown up a lot in the news, those in BC and following this stuff are familiar with it, with the deplorable conditions at some of their sites and being taken under administration by the health authorities, but also just the fact that it's the first foreign-owned equity firm that came into BC. So followed by Park Place Seniors Living, and then Sienna Seniors Living. And I should also give honorable mention to Rivera, another company whose name has been making headlines across the country, also for really poor conditions, received almost the same amount as Sienna Seniors Living. And you can see Retirement Concepts, this is for the fiscal year 2018-2019, received just shy of $1 billion of public funding. And I was also going to share, obviously, a popular slide today, a few things that the Seniors Advocate had to say about for-profit and not-for-profit operators in long-term care. So we can skip through this. Margaret's already touched on it. And that for-profit, having the profit motive in the equation clearly impacts care for seniors and working conditions. Again, Margaret spoke about that a bit. In 2001, there was something much closer to a sector standard in terms of wages and benefit packages. And we also had a lot more workers employed in what we call the public sector or master collective agreement. So a lot more workers in long-term care were covered by that. But with that growth and expansion of private for-profit operators, it's changed. So we see a lot greater disparity between wages and benefit packages. So currently, this is just looking at care aides, but it's a similar pattern for other workers, support workers, clerical staff. Currently, a care aide working under the public sector collective agreement makes $25.33 an hour. On average, in the private sector, they make $21.66 an hour, but can start as low as $17.84 an hour. And if you were to attribute a dollar value to the benefit package, that disparity would be even greater. The benefits are radically different. So this, this change comes about, it gets exacerbated under the BC Liberals, definitely. And we see a crisis in staffing, particularly among care aides in long-term care. There's a recruitment and retention crisis, and yet we still see that disparity in wages and inequity in working conditions. And as Margaret talked about, you have lots of workers in long-term care, not just the care staff, also support staff having to hold more than one job. So pandemic hits in March, and within months, Dr. Bonnie Henry, our provincial health officer in BC, issues single site orders for our province. That happens all across the country for the most part, but it's done somewhat differently here. And so the objectives of those orders, of course, are to try to prevent the spread of COVID, and they restrict workers to working at just one site. And as Margaret discussed, and I've just mentioned, you can see where that would lead to problems for staff who are reliant on having multiple jobs to be able to make ends meet. The single site orders also ensure that facilities have enough staff, that there's continuity of staff. And the piece that we did differently in BC, Margaret spoke about, was the leveling up of wages. There was also an effort made to ensure that workers had enough hours. So previously, where they might have been able to work for several employers, with these single site orders, they had to choose one. And that new employer, or not new employer, but single employer, had to make every effort to try to get them the number of hours in total that they would have helped previously. So if they had 30 hours a week between 3 employers, that new single employer would be trying to give them 30 hours a week. And there doesn't seem to be any problem with that. There is a shortage. In fact, they can't get enough staff, as folks might have heard. So the single site orders, they bring to light an existing problem. Oh, we're not there yet. Osman, thank you. It brings to light existing problems. And, something, a phrase that certainly made its way into a lot of reimagining long-term care publications, in which the HEU believes wholeheartedly, is that the conditions of work are the conditions of care. And there's 2 key indicators. Margaret touched on these as well. Staffing levels, so the amount of direct care that seniors are receiving in care, and turnover. You want to prevent churn. You want to make sure that you keep your staff, because it's that continuity, seeing the same people day in, day out, forming relationships, building the trust, and gaining knowledge about each other that's critical to quality care. And we have to make sure in going forward that we maintain full staffing and that continuity of staff well after the pandemic. We have to ensure that there's more care for seniors, and that care staff are staying around in the same with the same employer to create a better quality of care, which brings us to a discussion about accountability. Next slide. I'm only going to touch on a few key approaches. Margaret's already covered off many, and there are many more that we can use, and we should get creative about it. We need to maintain that standard of wages and benefits that's been created in long-term care. under the single site orders, and we need to level up benefits as well. Health authorities are currently using the same approach to funding. Well, 4 out of 5 of them are. They use a wage and benefit average when they're allocating that portion of funds to long-term care operators. So all operators are funded on that average, but some employers, especially the for-profits, choose to pay less. We have to take that option away from them. Don't give them the option to pay less and pocket the difference. We need to make them pay the standard that's set by the public sector collective agreement. And we need to mandate staffing levels and monitor and enforce them. So as we saw in Margaret's slide as well, the for-profit operators under-deliver on care hours that they're funded to provide. And currently the number of direct care hours that operators are asked to provide is just a guideline. We need to mandate it and increase it at the same time while we're at it. And make sure that staffing levels are something that inspectors can monitor and enforce. And also make sure that health authorities and governments have access to audit private operators' payrolls. And finally, we should be putting new investment into nonprofits. So money for retrofits, renovations as necessary, but new builds need to be made nonprofit as well. Another finding out of the Seniors Advocate report from this February was that not-for-profit operators tended to invest $10,000 more per resident per year. So that equates to 24% more than for-profit operators. And real estate is one of the reasons why the for-profit operators are here in BC anyways, for that asset. Why shouldn't government own that and make that a public asset? And at the same time, make that stock of long-term care beds more secure. So we need to take money, we need to take the profit motive out of it that drives down quality care and ensure that we're providing better quality of care to seniors. So that's all I wanted to share, and I look forward to the discussions and questions. Thanks.
Thank you, Lou. And thank you all three of you for your presentations. Just a reminder to our audience, now is the time that we're inviting you to submit, if you haven't already, questions to the Q&A box that apparently should be on your screen somewhere. And Audrey will highlight some of those and send them in the direction of our panel. I'd like to maybe challenge the panel with something that occurs to me. It seems like many of the conversations that are happening in communities and happening in this forum were also happening way back in 2009, I think it was, when Kim Carter came out with her first report. And here we are years later, still struggling with the same kinds of issues. And maybe I'd like the first response, at least, to come from Pat, given your background in sociology. And here's my thinking. When I look at the different groups and structures that have created long-term care that exist in BC right now, and in fact are operating long-term care in BC, it occurs to me that there is one voice that has not been actively engaged in that dynamic, and it's still not engaged. And in BC, that voice seems to be often, sometimes aggressively marginalized by some players in the for-profit sector. And I can add, unfortunately, that seems to be happening with the tacit approval or consent of the Ministry of Health to marginalize those voices when they do try to speak out. And that voice would be the voice that comes from the very people who are sending loved ones into long-term care, families and friends of residents. They've never been included in an authentic way. And I'm talking, as you might guess, especially about family councils in BC. These people are the very canaries in the coal mine. They know what's working and what's not working. And an association like ours, and unfortunately we're the only one in BC, we have the unique ability to, because of our networking, to quickly identify what's working and not working. But in BC, there are no regulatory requirements that anybody listens to us. So would you care to comment on that?
Yes, I mean, yes, you're right. And we like to talk about how all those who live in, work in, and visit in long-term care should be part of the decision-making process, should be centrally and legitimately and effectively participating in the kinds of decisions that are made. And I think that those extend to things like the physical structure of the building, and that the physical structure of the building should accommodate their participation. I think that we also have to not rely on their labor. One of the things that has become really obvious in my province of Ontario during this pandemic is the extent to which families provided direct care. There's been a lot of talk about how families provide social support, and the suggestion isn't that isn't a central part of the labor, which we would argue it definitely is. But the real story is the extent to which people didn't get to the toilet, didn't get to eat, didn't get to do a lot of things without the family there, because we have come to rely on them. And of course, many of those family members also look after people who are not members of their family. There are a significant proportion of people in long-term care who have no family, and family members are doing that too. So to go back to what Lou and Margaret said about accountability, it has to be accountable to the people who live in, work in, and visit in long-term care. Those are the structures we need. And that can't be the case if you're having to report to shareholders. And that's what a company has to do. Their job is to make a profit for shareholders. And I started out with those forms of privatization, in part because I had a pretty good guess about what Lou and Margaret were going to say. But also because we have to think of that unpaid labor as well, in addition to all of the reasons you talked about earlier.
Mm-hmm. Lou or Margaret, any thoughts?
Well, I just say that I'm very surprised that the pandemic is not a moment for giving more traction to the relevance and importance of families. Certainly in the sort of public narration of how these, these outbreaks are playing out, there's so many compelling voices for family input into decision making, and it just really surprises me that your perception is that plus ça change, nothing's changed since 2009. And I guess the question is, how can that sort of collective public energy around long-term care be used to give families a greater role? So that's sort of more an organizational political question than anything. Mm-hmm. Yeah.
If I could quickly say something else, the report that was put out by the Royal Society of Canada lists the many, many, many studies we've done of long-term care. We know what needs to be done. We need the political will and the appropriate funding and the appropriate transparency and the appropriate decision-making structures to do it.
Mm-hmm. Any thoughts, Lou?
Yeah, I'm surprised it hasn't been implemented already in BC, and I sure hope it happens soon. It needs to happen in a way that it's properly resourced, and that
Well,
it is
we,
mandated across the province. I
yeah,
also think, like, I know some of the issues that, of course, our members run into when they're wanting to report quality of care issues. And there's the fear of repercussions, and I can only imagine it being amplified for family members. So whatever we enact and put in place has to ensure that those
yeah.
protective measures are there too.
There is a policy, there is a proposal on the desk of Minister Dix right now, and it's been there for a year and a half, about having regulatory language. It doesn't cost a penny. It just guarantees that collective voice, and it still hasn't happened. I don't know if it's the slow-moving bureaucratic wheels or what it is, but I can tell you this. Um, there's a situation going on right now where we have a very large provider, for-profit provider, who has decided to, I'll give you an example of one facility. They announced to the duly elected chairperson, elected by family members of the family council, who was acting independently according to terms of reference that they developed. The company came in with rewritten terms of reference designed by the company, and then announced that they were probably going to appoint a staff person as the new chair of the council. Now, of course, what that does is it creates a filter, so any ideas or concerns that family members have are first filtered by, the corporate written rules of operation, and then possibly by a staff person. And the Ministry of Health is aware of that situation. And so one thing we can do to help move the needle a little bit and to grant that voice is to talk to the Ministry of Health and convince them, look, it's time to do that. In very much the same way as PACs work in schools. The community wants a voice in the kind of decisions that are being made. So it's a good idea. Isabel McKenzie has tried to make a move in that direction with the creation of with the suggestion for the provincial body of associations, but it needs more than that. It needs regulatory language. It catches up, in fact, to other provinces in Canada. So, any other thoughts or comments on that?
It's not directly related to that point, but one of the ways you get teamwork and a place that is not just a place to live, but a place where there can be joy, is when everybody is part of the same organization. So to go back to what both Margaret and Lou mentioned about contracting out services within, like the food, like the cleaning, like the laundry services, really completely undermines what goes on in the home. And I have to say, the complaints we've heard most from families as we've been studying this for the last decade is about food and clothing. That they're central to care and that they're not good when they're contracted out. There's lots of research indicating that, and we certainly witnessed that because we actually ate food in all of the places we were in. And those parts of the long-term care home that families in particular have pointed out for a long time have to change. They have to be part of what goes on in the home, and those people need to work in the home and be part of the care team.
I was struck, I think it was last March, Isabel McKenzie was having our seniors advocate was having a conversation with one of the news agencies, and she referred to some for-profit facilities in terms of being partners in delivery of care. And she said, we're not partners. We shouldn't be partners. We are regulators as a province. we're using public dollars, and I'm quoting her, to contract with somebody to deliver public service. They are not equal partners at the table. Their interests are not equal to our interests. Our interests are the public interest, and that needs to take precedence. Comments about that?
My comment is good quote.
Yeah, I was quite impressed with it. Audrey, how are we doing with questions?
We have a lot of questions.
Okay.
And I have been trying to, there's a lot of repetition and kind of themes. So I'm going to, rather than read out specific questions, try to draw out a few themes. And I'm going to start with maybe maybe this is challenging, but there's a lot of questions about, kind of referring to like, we agree, the evidence is there. What needs to happen for change to come? There's, what can we do to change the minds or the priorities of kind of decision makers, and like how do we get going on this?
Comments, folks? I think you need to unmute.
If I could start this conversation, Marcy Cohen and I just produced a paper for the Canadian Centre of Policy Alternatives suggesting federal standards for long-term care backed by funding and enforcement that requires a lot of the things we've heard about today. I think that's one place we can start. Is the throne speech said they would introduce national standards. I think we have an opportunity right now to have some say in what those standards are and how they're enforced across the country. And I think it's a very important place to start the work.
Maybe I can jump in there because there's a specific question about this directed to you, Pat, from Carolyn Hudson. She is asking you to elaborate on your position that policymakers should more effectively integrate long-term residential care into the public healthcare system through federal legislation similar to the Canada Health Act. And specifically, Carolyn is asking, in other words, separate legislation. And there's a few other questions about integrated these federal standards into the Canada Health Act. So I'm curious about what you would say to that.
I would say, I think we first need to agree on what the standards are, and then we can figure out how we proceed. I think that I certainly feel there needs to be federal leadership. I certainly think it has to be along the lines that the Canada Health Act is, that said, if you want our money, you need to follow these standards. And I think it's really, really important to emphasize these are standards, not standardization. They're about meeting principles and criteria, not about one size fits all, but they do require transparency. And to go back to the seniors advocate in BC, there has to be verified data. We have to have accurate data to base that transparency on.
Pat, not having seen the CCPA report myself, and perhaps many of the listeners, can you summarize what you would propose as your top 5 standards?
Well, I should say we suggest 2 things. One is a national labor force strategy, which, as you know, has been recommended by every commission that we've had. And if we're going to end up improving the conditions of work in long-term care, we need a national labor force strategy, as the OECD and the ILO and the WHO, all of those international organizations have been recommending. So what we've said in terms of the national standards are, first, access based on assessed needs, not on ability to pay. Second, the establishment and enforcement of minimum staffing levels based on current research, verified data, and an assessment of social, emotional, and clinical needs. Next, a plan to ensure that 70% of the staff work full-time in a single site, with the remaining 30% being permanent part-time staff to provide needed flexibility. And this would ensure, as both Lou and Margaret said, that all staff have benefits and pay based on equity principles. Next, a plan for physical environments that ensure safety and social supports for residents, family, staff, friends, and volunteers, including surge capacity to address infections. And we include in the notion of physical environments things like PPE and methods for effectively dealing with laundry and waste and room size and ventilation, the kinds of things that Margaret raised earlier. Education and training standards that support the existing staff as well as new hires and are developed in partnership with public post-secondary institutions and organizations representing the relevant occupations, and that education and training should also be provided to families and volunteers, to go back to Kim's point earlier. And two final ones, policies require transparent, verified reporting to ensure accountability to the public and compliance with the standards that I've just listed. And finally, a plan to ensure that all public money goes to public or nonprofit organizations, including all subcontracted services. More or less what you both said.
I guess one question I'd like to jump in and pose to you, Pat. So on the last point about all public money and going to not-for-profits, absolutely, of course, wholeheartedly agree. And what would you say, or Margaret as well, to, you know, what gets put forward sometimes by advocates of for-profit care, that we eliminate or take over the contracts for the existing for-profits? What do you think about the feasibility of that?
It's Margaret's turn.
Yeah, it's a tough one. I think that it's difficult to intervene when a for-profit facility may be providing decent care. And I think we do have to be careful about saying all for-profits bad, all nonprofits, public facilities good, because that's not people's experience for sure. And just because the research, which applies the law of averages, finds that, it doesn't mean that there isn't variation within those groups. That said, I think that for-profit facilities who persistently demonstrate themselves as bad players, that persistently are not able to meet staffing levels, have high turnovers. The hope would be that you regulate those facilities enough so that it's no longer profitable to actually, it becomes clear that you can't, there's no business case for facilities that go after a big profit margin. Should we get rid of all facilities, including those are owned and operated by, say, a nurse, you know, who has a lot of pride in her facility and does a great job? Probably not. So I think it does depend. I think the more scale the drive for profit becomes, the more problematic it is in terms of really providing public accountability for care.
And I can add to that, we do have some members in our association who speak well of their for-profit facility. They tend to be smaller facilities that develop more person-centered kind of care. And, you know, some of the discussion that we've had in our group is that the idea of, if we're going to reduce our dependence, as I think Pat said, on for-profit facilities, maybe it makes sense to first target underperforming government-funded for-profit long-term care facilities. Begin that way. Thoughts?
I completely agree with Margaret as usual. And but I think if we set the standards high enough, it's not going to be an attractive investment. You're not going to be able to go into it to make big bucks. You're only going to do it if you're interested in providing care. And I think that one of the mysteries right now is where these big profits come from, given the claims that are made, especially in my province of Ontario, that all the staffing money goes to staffing, and yet mysteriously the wages are lower and the staffing levels are lower. So there's something interesting going on there. We need better data. We need to know about what is exactly going on, which is, as Margaret pointed out, the Seniors Advocate in BC made available.
I think we need to know a lot more about their operating structures than what we have. And it seems that the US, if they're receiving Medicaid, Medicare funding, that they have to report out a bit more on that. They have to give a bit more detail on their corporate structure, but we don't seem to require anything in BC in that respect.
I certainly think that it would be interesting to require the posting of how many hours facilities are paid for that are actually delivered as a public reporting out function. The Office of the Seniors Advocate actually does a very good job every year of report. You know, she surveys all these facilities, so you can find out who subcontracts, you can find out the staffing levels. But I think having a kind of report card on simply whether facilities are actually delivering the care they're paid for delivering, I think would be a really reasonable request in terms of public investment.
I'll paint a picture of what happened in one of our member council's facilities. They were looking at the use of care aids, and it seemed to be an extraordinarily, there was use for them in things that weren't related to direct care. And they monitored it more closely. And the chair of the council took her concerns to Island Health and was actually told that, well, this isn't really the responsibility of a family council. They made it their responsibility anyhow and pushed. Finally, there was an investigation done, and it was determined that, yes, reporting, it's all self-reporting at that time, was inaccurate, and thousands of hours had disappeared from direct care. The problem was it took 4 years for them to come to that realization, and which is just another reason for that, you know, family councils to be supported and listened to in the observations that they're making. So. Other questions?
There's maybe to shift the topic a little bit, a question about from Helena: where will we get the caregivers who are well qualified and well paid? So where do the workers come from? And then maybe another question I've lost track of, but was asking whether paying workers well would cause some of these homes to close if there's not enough profit. So I will let you go on the maybe a little bit down the workers train. Maybe Lou, you want to start?
Sure. Right now, you know, we've explained a bit the conditions of work in terms of they're not, I mean, even within the master collective agreement within public employers, there's still only about 50% of those care aid positions are full-time regular jobs as of like last year's data. So 50% are full-time regular jobs. So we see the issue. And those are the employers that are more likely to offer regular full-time work. They see that problem in recruitment and retention. They have a desire to increase more regular and full-time lines as an avenue to be able to attract and retain regular workers. you know, in terms of the wages and benefits there, those, of course, we need to strive to improve those, but relative to the rest of the sector, that is the standard that people are aspiring. Try to leave the other facilities that pay poorly or that are, you know, that the staffing levels are so low that it means huge workloads. So they don't want to stay there, and they're trying to get into those health authority operated sites. I think that speaks for itself and makes it clear what needs to happen. Like we have to have more regular work and with proper conditions, and it will attract people. You know, we were facing this recruitment and retention crisis for quite a number of years. It was all visible. We're heading into it. And then we saw governments, province after province, right? Quebec, Ontario, and now BC, quickly establish these programs to quickly school people and turn them out quickly to be carried. So when the crisis hit, they were able to do it and the will was in place. Here in BC, we're going to pay workers to go to school. We're going to pay their tuition. We're going to, it's an apprenticeship type program. We've worked it out with the union. We've established a temporary job description. They're going to have union rights while they're doing this. There's not going to be an opportunity cost to them. That's the way it should be. If you need these workers, you have to treat them with dignity and show them the value.
If a number of years ago, we did a study comparing the Nordic countries and Canada, and asked, one of the questions we asked of staff was, do you face violence on a daily or almost daily basis? And those responding in Canada were more than 6 times as likely to say that they faced violence on a daily or almost daily basis than was the case in Sweden. The big difference between, and in Norway, I should say. So the big difference was in staffing levels and in the conditions of work. That not the difference in terms of the residents, and that the levels of violence are themselves a reflection of the fact that we don't have the kinds of conditions that I was talking about. So it's important for the residents too. I mean, I can imagine feeling violent if I had for hours tried to get someone to help me to go to the toilet, or if I have a tray of food sitting in front of me that I can't eat without somebody to help me and nobody's come to help. And of course the staff goes home, as we heard over and over again in that study and in the Reimagine study, that the staff say they go home and cry because they haven't been able to provide the kind of care that they have know should be provided, that they have the skills to provide, but they simply don't have the time or the other kinds of supports they need in order to provide that. And that's all pre-pandemic.
It's another aspect too, Pat, that you raised. I know it wasn't your your main point, but thinking about the injury rates that
Absolutely.
Certainly there's a difference depending on the staffing level in a facility, as you just pointed out. But those injury rates in BC, 8 of every 100 workers experiences an injury that has them take time off work, right? And 8 in 100, like it's that many more care aides we could have on the job if we address the injury rates. It's appalling, and it's barely decreased over the last decade.
Yeah.
Maybe I'll jump in with another question from Dar. Is the funding currently available to level up and ensure consistent higher standards of care? And if not, does anyone have proposals for where the additional money will come from? Are there other services that should be cut or taxes be increased? And generally, is there public support for increasing spending?
I'll just offer a thought. Our association is involved with some family practice, divisions of family practice initiatives. And one of them is to get physicians involved in long-term care in a more proactive role. Okay, now that seems, so they would enter more often in a more robust way into long-term care. And one of the things that is coming out of it, it seems, is actually a reduction in costs because residents aren't entering into acute care as often. And so what I'm suggesting is that if you invest money up front more often, there may be an economic case to be made for that being a good idea, because you're not paying, you know, the tremendous costs associated with things like acute care. What do you think, Margaret, Pat?
Absolutely. I mean, if you cost out some of the research around hospital admissions and transfers to the emergency department by for-profit or staffing, you can see that there's huge gains to be made by reducing hospital use through both better staffing and changing the business model to a nonprofit or government-owned type of model. So I think, though, the question was, if I'm mistaken, it was around, are we going to maintain the same levels of staffing and wages as we have in the pandemic, post-pandemic? Was that one of the questions? I didn't quite, because
the question was about where's the money going to come from?
Well, we're making the money now for a lot of the lift ups and leveling. And so I think the question is, we need to make that money continue. And I think it is a moment now in terms of a collective awareness around the importance of seniors care in long-term care. So I think there's a much more of a political will and also a popular support for valuing the workforce in the sector. And I think it's a really good moment to try to consolidate it.
I think we should also talk about investing in the care economy. When we invest in care service, the money doesn't get buried in a hole. People have jobs, they buy things, the economy goes around. I think the federal government, we can get some of the money from the federal government, but also, yes, we have to think about taxes. I would agree, but I also think we talk about investing in an infrastructure. This is the most important infrastructure we have in many ways. I mean, along with food and water, but it's absolutely critical to our well-being. So why aren't we seeing this as an investment as opposed to only an expenditure?
And going back to your earlier comment, Pat, about the cost on the books, right? That immediate output. And a point I was trying to make in the measures I think we need to take around accountability and ensuring that from going forward in BC, well, in all parts of the country, that investment is put in not-for-profit facilities and government-owned facilities, because it is a public asset. We know in BC under the Liberals, there is, I forget the name of the report, but it looked at, I think it was 3 different P3 builds that were extensions or parts of hospitals. And when they looked at the financing of that, we just pay and pay and pay those, astronomically long commercial contracts to private investors, and they're paying huge private interest rates. If we were doing that as government and using our own money, we'd have big cost savings right there.
Mm-hmm. Mm-hmm.
So I'm going to take a risk of airing into the topic for next week, which is the gaps in seniors care. But there's quite a bit of questions from our participants about home support and the desire for seniors to stay at home. funding for the community health workers who, are also struggling with quality jobs and providing that support. My question, I guess, to this panel, without getting too deep into those issues, would be how does that fit into the puzzle of this conversation we're having right now about long-term care?
I would say just, one point in terms of workers' wages and working conditions, we have to make sure they're on par. There has to be parity. So we're not pulling from one sector into another. There's a good report that came out after SARS in Toronto that showed quite clearly where the pulls and pushes happened in terms of workers gravitating into one sector versus another. So we have to make sure there's parity. So we're not leaving one aspect of seniors care high and dry for staff.
I think that this is one very important reason why we need a labor force strategy that includes the entire sector, so that people go to work in the areas where they want to work rather than where they can afford to work or not afford to be able to work. That's one thing I would say. The other thing I would say is I have long been a very strong supporter of care at home, and that we have to certainly get better at it, and we have to start doing 15-minute communities, and at least in Ontario, make sure the snow is shoveled. But we also have to remember, and I think COVID has made this very clear, that not everybody has a home, and not everybody's home is safe, and homes can be very lonely. So I think that, well, I obviously support home care. I think we also have to think about positive congregate living. And it's part of our argument on reimagining long-term care. As Margaret pointed out, the care needs of the people who are in long-term care are really extensive. And it would be very hard to provide many of those in a private home.
That said, we can do a lot more.
Absolutely.
There. And I would say, relatively speaking, it is a bit of the poor cousin of institutional care at the moment. And as someone who just does house calls now with a team of nurses and other practitioners, I really feel we need to invest way more in supporting people to live at home as long as is possible. And there's so much more we can do. And as Lou has referred to, part of it is to regularize the jobs of people working in the sector, to really kind of address some of the challenges with being a home support worker, which is it's kind of lonely work. You're on your own, you go from home to home. There's far less camaraderie, and really sort of trying to figure out how to make the sector as attractive to workers and also as accessible to seniors who want to age in place.
Great. Well, we're getting close to our end time here. And I want to thank all the participants who submitted questions. There was over 100 questions submitted. So unfortunately, we won't be able to get to all of them today. But I want to thank all of our panelists, Margaret, Lou, Pat, and our moderator, Kim, for engaging with each other and engaging with our, our questions. And thank you so much for making time to be with us today. I want to note that the recording of this webinar is going to be sent out to participants, and so you'll have access to the presentations, and we'll be able to review the slides in that. And also another reminder that next week at the same time on December 1st, we are doing another webinar, and we're going to be digging a bit more into this issue of the whole continuum of seniors care and the current gaps in the system. So please be sure to register and join us for then. I think we'll be if it maybe we'll just repost. There you go. The webinar registration link has just been posted in the chat, so we'll make it easy for you that way. And finally, I'm struck by the number of comments and also questions that refer to what do we, the public, do? So I want to encourage all of you to stay tuned to the BC Health Coalition as we're exploring more of this issue of seniors care. It's our role as the public to figure out how to use this knowledge and this the expertise that's been shared with us today and put into action and figure out how to move the needle. So we'll be following up with you and hoping that there's work to be done collectively moving forward. So on that is 125. Thank you everyone for being with us today. Thanks again to all of our panelists and to Kim and the tech team and everyone who joined in.
Thank you, Audrey.
Bye.
Bye-bye, everyone.
Thanks.
Thanks.